Hi, this is Tom Inge, and I really do appreciate the opportunity to come to the Society meeting via screencast and talk to you about the mid and long-term results of adolescent bariatric surgery. I really also appreciate the fact that a huge focus has been placed on this topic of pediatric obesity and surgical treatment at the Mexican Association meeting, and I think that it is very timely and an important topic given the prevalence of obesity and severe obesity in children both in your country and in the United States. One of the research studies that I'll be talking about in this presentation was sponsored by Ethicon Endosurgery. It was investigator initiated and provides us with a glimpse at the longest term outcomes that I've seen in the U.S. So the objectives of the study are to talk a little bit about the rationale for surgical treatment of adolescents with severe obesity, to describe outcomes of the Teen Lab study, which has 3-year outcomes now, and to also review these longer-term outcomes that I mentioned. Certainly, we're all aware that both the United States and Mexico have a major problem when it comes to overweight and obesity. Here you see the headlines as of last year, suggesting that Mexico was slightly outpacing the U.S. In obesity prevalence. And in fact, when we look at overweight prevalence, what we see here, and I'll just grab a laser pointer real quick, we see that some estimates have Mexico again in the essentially 70% range for overweight prevalence. And that is, again, slightly greater than the U.S. prevalence, which is in the 65%. And this is adult data, overweight, not obesity. But when you look at the rest of the peer group, if you will, the international community, we see that both the U.S. as well as Mexico have a major problem with weight. In pediatric age groups, we also see a very dominant influence in Greece, with 38 to 44% of Greek girls and boys with overweight, and in Indonesia, very small problem with overweight. In the U.S. and Mexico, we're essentially neck and neck. About 30% of boys and girls in both countries are suffering from overweight. When it comes to more severe levels, though, of obesity, what's happening in the U.S., we have our arms around, at least several years ago, in 2014, we can see that overweight, again, right about 31%, obesity in pediatric age groups, about 17%, or 13 million children in the U.S., and those with severe obesity in the 6 to 8% range. We're estimating that those may be 5 to 6 million in numbers in the severely obese range, the range where you might consider surgery. So that means that severe obesity is really more common than pediatric cancer, congenital heart disease, celiac disease, cystic fibrosis, and autism all combined. So we all know that obesity in and of itself causes a long list of health problems. Those problems include diabetes, high blood pressure, high cholesterol, and also kids just don't feel like kids. Their quality of life is pretty lousy, at least at these higher levels of obesity that we're examining here. What happens when we think about weight loss then is that there is a very significant reaction, biological reaction, that the body has when weight loss occurs. So we're perfectly capable of losing weight, okay? but the vast majority of us are not capable of maintaining a weight loss, and that's due to what are termed physiologic adaptations which promote weight gain. Those include reducing energy expenditure, increasing efficiency of muscular work, reducing sympathetic tone in the sympathetic nervous system, also increasing appetite, and appetite hormone levels can be measured to demonstrate this. There are also very real decreases in gut hormones that control our sense of fullness or satiety. Now, on the other hand, surgery, when we're talking about modern bariatric procedures, does effectively overcome the body's ability to regain weight after initial weight loss. And this is mediated by a number of players, but including GLP-1, oxyntomodulin, PYY, these hindgut hormones, if you will, but also CCK, bile acids certainly play a role, as does ghrelin. So all of this to say that it's not just stomach stapling. There are a number of mediators, including in all likelihood the colon bacteria or the microbiome within the GI tract, that helps surgery to counteract the very powerful ability of the body to regain weight after weight is lost. So what happens when we use surgery for teenagers who are severely obese? The Teen Lab study was designed to examine some of these outcomes of surgery. It's a multi-center prospective study that includes Cincinnati Children's, it includes Nationwide Children's in Columbus, UPMC or University of Pittsburgh, the Texas Children's Hospital down in Houston, and also the Children's Healthcare System of Alabama in Birmingham, Alabama. It's sponsored by the National Institutes of Health in Bethesda. We recruited 242 consecutive adolescents who were less than or equal to 19 years of age at 5 centers. And we studied them before the operation and at multiple time points after the operation. In fact, the average now is about 6 to 7 years out from surgery. The entire cohort is now 4 years out from surgery. The main aims of the study were to determine what are those health benefits, what are the weight benefits of the surgery, and also, importantly, what are the adverse effects that we might see after surgery. Baseline characteristics are shown here, mostly a female group, mostly white females. The age at surgery, 13 to 15-year-olds were about a third, 16 to 17-year-olds about a third, and 18 to 19-year-olds about a third. The body mass index, greater than 60 in 1/5 of our participants. About a third had BMIs in the 50s, and 44% had BMIs in the 40s. The median or average BMI was 53 in the study. These are the operations that were performed. The vast majority underwent gastric bypass. A number of them underwent 67 that is, underwent gastric sleeve resection, and then a very small number underwent a lap band placement. The weight changes that we saw from baseline included a drop in the first year by about 30% for both sleeve and bypass patients. When we look at the longer-term data, there's a very gentle increase in BMI or weight following the surgery between 1 and 3 years, so that in both groups they achieve a durable weight loss at 3 years between 25 and 30% down from their baseline. Importantly, we have actually a very good visit completion rate with 90 and 86% at 2 and 3 years respectively. Another way to look at BMI change is to look at the histograms. And so what we see here at baseline in red and at 3 years in black is the histogram, if you will, for the distribution of BMI, with the most common BMI preoperatively being in the 40 to 50 range, and the most common BMI postoperatively, also 22%, being in this same range. However, when you look at the curves overall, you see that at 3 years there's a much broader distribution of that, with far more down in the either non-obese or only mildly obese categories. Health outcomes were a major focus of this study, and here we look at diabetes, prediabetes, dyslipidemia, elevated blood pressure or hypertension, as well as abnormal kidney function. What we see when we look at the data on the right-hand side here is the remission of these conditions. So what proportion of individuals that had the condition at baseline no longer have the condition at 3 years? And what we see for type 2 diabetes is approximately 90% remission. For prediabetes, 77% remission. For dyslipidemia, 66% remission. Elevated blood pressure, 73% remission. And abnormal kidney function, 86% of them revert to normal kidney function. Let's look at the kinetics of this change for dyslipidemia. Those with dyslipidemia at baseline were in the 70 to 80% category, and then by the time of the first year, the vast majority of response to dyslipidemia had occurred, with prevalence of dyslipidemia dropping from, again, 70 to 80% to 20 to 35%. There was similar resolution of dyslipidemia in both sleeve and bypass participants, again, out to 3 years. We certainly do want to follow these kids longer and determine whether there is any differential effect between bypass and sleeve on some of these important outcomes. If we look again similarly at the kinetics of change in the prevalence of elevated blood pressure, we find here that very similar improvements occur in elevated blood pressure in sleeve and bypass patients over time. Again, with the bypass patients starting with approximately half of bypass patients started with elevated blood pressure, and approximately 20%, 15 to 20% at 3 years. When we compare this kind of outcome for elevated blood pressure and dyslipidemia to what you might expect for adults undergoing these same procedures, what we see is that the adolescents do have a greater resolution of these comorbidities after surgery, whether it's type 2 diabetes, elevated blood pressure, or dyslipidemia. And that, I think, will be the topic and the subject of a dedicated publication in the future. What about quality of life? This is one of our patients that underwent a sleeve gastrectomy, and she believes that she got a new life out of this operation, and I believe that there are many ways to also support that scientifically. One of the ways is to look at depression scores, and we measure depression with a Beck Depression Inventory, and that is an instrument that allows us to say how many are in the clinical range for depression. And as you can see, the BDI score falls dramatically even by the first year, 18 months, and by 24 months. 65% are initially in the clinical range for depression scores, compared to 12% in the clinical range at the 2-year follow-up in this study that we published in 2011. This was an interesting study that we did, and I know that this is supposed to be mid and long-term results, but in this study we looked at very short-term results because we hypothesized that the operations that we're doing, in this case mostly VSG. I think that there was one patient here in the red with a gastric bypass, but most of these are vertical sleeve gastrectomies. There was a remarkable improvement in obstructive sleep apnea when measured objectively in a sleep lab with baseline apnea hypopnea scores in the 15 on average, falling to 5 by day 18, and then remaining at 5 on average by day 39. So similar to the effect of surgery on diabetes, where we have this remarkable improvement metabolically before we have even substantial weight loss for diabetes, we similarly can report now that there is a apparently weight-independent effect of the operations on sleep apnea as well. But part of this talk was looking really at long-term outcomes. So what is long-term? In my book, long-term is anything beyond 5 years. And the questions really become, what happens if we do not effectively treat pediatric severe obesity? What data do we have on long-term outcomes of non-surgical treatment? Is the weight loss durable after surgery? And what are the long-term adverse nutritional effects? I was going to go over this by starting with some methodology. This is the long-term outcome study that we named the follow-up of adolescent bariatric surgery at 5+ years. So on average, the surgical patients in this study are approximately 7 or 8 years out from surgery. We did this study in an interesting way. We actually looked back at our lists of patients that we operated on from 2001 to 2007. So in 2014, let's say, we called back in a patient that had had an operation in 2001, and we did a very rigorous research study, one study visit, multiple years, greater than 5 years after surgery. These were all gastric bypass patients, and all of them were adolescent at baseline. Certainly they had grown up and were in their 20s at the time of the study. But the other interesting feature of this study, the FABS-5 study, was this non-operative group. We looked back at the lists of patients with severe obesity who had sought medical treatment at our hospital back in the same time frame. And we actually called them back in as well, and we ended up with a sizable group of about 30 there. We hypothesized that the surgical weight loss would be durable and that health would be improved. The follow-up of adolescent bariatric surgery study then recruited 58 adolescents or former adolescents who had undergone surgery, and that was 81% of those in the group that was eligible for the study. They were 17 years on average at the time of surgery, with a mean BMI of 57 at the time of surgery, and their average follow-up was 8 years. On the non-operative side, our program is termed HealthWorks. There were 30. Their baseline age was 15. Their baseline body mass index was 51, and they were 7.3 years from their baseline characterization prior to medical weight loss. What were the long-term BMI outcomes? They're shown here. The non-operative group went from a body mass index of 51 to a body mass index of 54 over those 7.3 years. However, in the surgical group, you can see here the BMI went from 57 down to 34 at 1 year, and then very gradually increased to 38. So this was a major finding for us, and the fact that we had 81% of our eligible patients meant that we weren't losing a lot of patients to follow up and therefore wondering whether the surgery was really effective in the group. In the majority of the group, the surgery was quite effective and durable. What about diabetes outcomes? Only 16% of the surgical group and 10% of the non-surgical group had diabetes at baseline. However, at long-term follow-up, what we saw was that the surgical patients with diabetes were only 2%, so 16% to 2%. Whereas the medical patients, the patients who did not undergo surgery, none of them resolved their diabetes, and on top of that, there was an additional 14% who developed diabetes over time. So although this did not reach statistical significance, we certainly do appreciate the fact that 10% to 24% is a substantial worsening of metabolic status. What about high blood pressure? Surgical patients, 38% at baseline had high blood pressure, and it was about half, or a little bit more than half, that resolved their high blood pressure at the long-term follow-up. On the other hand, for the medically treated patients, 20% prevalence of hypertension at baseline, it doubled at their long-term follow-up. So there is certainly, within this data, evidence of a dramatic health cost to not having this severe obesity adequately treated. What about dyslipidemia? There again, we see a difference in results, with surgical patients dropping from 86% prevalence to 38%, medical patients undergoing no significant change. Nutritional status at 8 years is shown here, with gastric bypass patients demonstrating levels of low albumin, 2%, low iron stores at 60%, and that was statistically significant. Anemia, 46% in the surgical group and only 4% in the medical group. No difference in B12 levels. There was a higher proportion of gastric bypass patients with elevated parathyroid hormone than after non-surgical weight loss, suggesting that there may be a problem with bone metabolism that is evolving. There was no difference in alk phos, vitamin D, or low folate. However, both groups had substantial numbers of participants with low vitamin D levels, 78 and 82%. So to summarize, severe pediatric obesity is rarely reversible. And I've shown you data now that demonstrates an 8% increase in BMI for those severely obese adolescents who are, when we check back in with them at 7 years after initial attempts at treatment, non-surgical treatment that is. There are poor health outcomes that are expected for these children with severe obesity, as I demonstrated: worsening rates of diabetes, worsening rates of high blood pressure. Bariatric surgery does result in durable weight loss as well as significant improvement in health. It allows the BMI to decrease and remain reduced. So it's a durable treatment, and that is a message I think that has not been adequately delivered. It certainly does improve depression and quality of life, and it corrects a whole host of metabolic problems, as we discussed. Surgery does have risks, and I know that other speakers at this conference are talking about the complications, which can be serious. Even the nutritional effects, very little is known about the adverse effects, and we're just now beginning to shed some light on that with these data. And we believe that there is a great reason to make sure that these teenagers and their families understand what has to be done to prevent nutritional problems down the road. I think that there's also reason to talk about this window of opportunity to reverse severe pediatric obesity. What we see is that late surgery at high BMIs, very high BMIs, results in residual high BMIs. So 8 years after the patients underwent gastric bypass in our group, what we found was a BMI of still 38. Now that's down from 56. Okay, so that's a major improvement, but they still are going through life at a very high BMI. I think that if we had operated on them sooner with BMIs in the 40s, that there would be fewer of them with severe obesity. So this cartoon captures, I guess, the current thinking, which is that for kids that have BMIs at the 95th percentile to somewhere around the 120th percent of the 95th percentile, we should be looking at intensive lifestyle interventions. But when the BMI has reached 35 with major comorbidities, or when it's reached 40 with other comorbidities, we really should be considering surgery before the BMI gets up into the 50 plus range. So with that, I think I'll thank you again for the opportunity to present this material, and I'll also thank a whole team of people at our center and multiple other centers that contributed particularly to the Teen Labs data, and look forward to many more manuscripts and data from this study. And again, thank you for your attention.